So I will be talking about OCULENTIS EDOF. I will just skip through basically the material is same like what we have seen with Zeiss. That's the hydrophobic surface and hydrophilic material, and they use the submicron lithium technology. So good thing is that it has a very sharp edge, and I have not seen any PCOs in my 1 year of use. And basically it is different from other IOLs because it is asymmetric EDOF. That means one part, the lower part is for near and upper part is for the distance when you implant it this way. You can implant it in various other ways also. My practical experience is that though it says that it's a refractive bifocal by design, just stop the noise. It's a varifocal IOL. That means the transition zone between the distance and the near which they have created also gives some amount of intermediate vision. So this is how it looks, that from the near, the light is focused on the macula from the lower segment, and the upper segment focuses for the distance. These are different types which are available in this particular model. The ones which I like are the Lentis Comfort and Lentis M plus X, which are available in India. But Lentis Comfort more so because it has a wider central, you can see, distance zone of 1.15 mm. That means any patient having even larger alpha, angle alpha, they will not lose any vision, they will not lose any contrast. At the same time, it has addition of plus 1.5. So the transition zone is much smoother. M plus X is good for someone who is a avid reader. It has plus 3 addition, but you can see the central zone is just 0.8 millimeter, the left side. And that's why there will be some loss of contrast sensitivity if the angle alpha is not appropriate. So this is all basically how it is. You can see the upper one is the monofocal, so they are happy with the distance, but they are not happy with the intermediate. But with Lentis Comfort, they are happy with the distance as well as intermediate. M plus, there will be some area where for the intermediate there will be loss of vision, but near is good. So generally my technique of doing this, so these are the results of the Lentis Comfort. What I do, you can see the fourth one, Comfort Binocular. So you can do a blended vision. That means one eye targeting emetropia, other eye minus 1.5, and they can have similar to what we do in Presbyond. That means a blended monovision because they have extended depth of focus. But I don't use that way. What I do is that I target little bit of myopia even in the distant dominant eye, and might be slightly little bit more myopia in the near. So it's like minus 0.25 targeted for the distant dominant and minus 0.5 to 0.75 targeted for the near dominant eye. So that reduces the problems of monovision, that is loss of stereopsis, etc. So what I found out in my patients, I will just forget about the slide. What I found out with these patients is that the dysphotopsia are hardly any. Nobody has bothered about dysphotopsia. The contrast sensitivity is excellent, as good as monofocal as which we tested even on Pelli-Robson chart. We have to, slightly modify our A constant. For example, the modify A constant which company gives is 118.2 with the SRKT. And what I target is 118.5. That means I target minus 0.3 for the rather than targeting emetropia or hypermetropia. And for the other eye, I see the result of the first eye. If it is, and the autoref reading it will give, if we have targeted emetropia is around minus 0.75, okay, not 0. So when I got minus 0.75 in the autoref post-operatively, what I will do is that for the other eye, I will target minus 0.75. Okay, if I get minus 1 in the first eye, then I will target the same in the other eye. Okay, so the patient has very good distance as well as near vision. And my experience with EDOF or any newer technologies, hydrophilic IOLs give much better, crisper vision as compared to hydrophobic IOLs. That is my personal opinion. I think it might be because of the surface, which is much better, or the maybe refractive index, which is much lower with the hydrophilic IOLs. So this was the comparison of photic phenomena. You can see the OCULENTIS have very, very minimal, severity. So not just the amount of dysphotopsia, even the severity is quite less. The typical, what they complain is of the angel wing. Okay, angel wings means around the light on the lower part. If the near eye is lower, they see a kind of, fan of light, which is very mild. And particularly they will see it during night driving, but still they can drive at night very easily. Regarding the, the position of the IOL, how you can put, the typically recommended is the left side position. That means near eye is lower, okay, but my experience is that it doesn't matter with Lentis Comfort because it has a smooth transition zone. The idea is that if your lens is like this, slightly infranasally the near eye, the photic phenomena are towards the near eye. That means the angel wing will be infranasal. And when it is infranasal, it will not affect your night vision. Okay. For near, it doesn't matter if there are some photic phenomena, because we don't, read in dark light. So that way it helps. Just a brief video, but I think I will just summarize, because I want to, I think Kumar Doctor has shown it's not a very difficult lens to put in if you have experience of plate haptic IOL. It's same to that. It's a very soft material. You can tuck it in. Of course, you should avoid, very small rexes like 4 mm or something like that. But 5 mm rexes, you can easily put it inside. And this is how I do. I just rotate it in vertical position, then tuck it in. You don't have to dial the IOL in. And use 1% hyaluronate so that there is no viscoelastic which is remaining. So I will skip the video and we'll quickly move on to some cases, because I want the panelists to discuss, because it's more important in instruction course to discuss their experiences rather than just giving some theoretical, information which we can read otherwise also. So let's start with I think one of the very important cases Dr. Nagwekar sir has shown, post-refractive patient. So, and ophthalmic surgeon. Okay. So this is a very common scenario that nowadays we face. Okay, 45-year-old computer professional, and they will either have bilateral cataract or unilateral cataract. So, okay, just within 30 seconds, just give your opinion, like, which one you will go for in such scenario, which lens?
Or unilateral, I would love to do a EDOF, because that will give him a good intermediate vision, and which is halos and glare free. And 45-year-old, I would do a VVT, because my experience with VVT has been fantastic. It's a great lens, and I hardly have to give him near ads also in many patients. So I'll just give plus. Binocularly.
Yeah.
Binocularly, I hardly have to give them a reading ad in VVT patients. So
next,
the most I'll give one.
Next case scenario, very common again, 25-year-old with traumatic cataract in one eye. We consider that patient has good potential vision, good pupil.
Yeah, I think again, my choice would be an EDOF. Absolutely. I mean, in fact, I said almost every case,
yes.
if one is concerned about the quality of vision.
Okay, 65-year-old housewife who uses mobile, doesn't read much, no driving.
I would use mix and match, like dominant eye comfort, non-dominant eye M+X, or VVT and Proxa, but I have not done more of Proxas, but mix and match is a good case for a mix and match.
I think I would think of a trifocal in this case.
Trifocal is a good choice.
It's a good choice.
55-year-old businessman, I would occasionally drives at night. Bilateral cataract, will stick to bilateral cataracts.
So again,
occasional driving, yes.
Yeah, no, even if he's occasionally driving, 55-year-old businessman, he'll work more with his computer and his mobile. So I think I would put an EDOF in this case.
Nitin, trifocal EDOF? Okay.
EDOF, yes.
6-year-old who has habit of reading a lot. Very simple.
Trifocal.
But I love to do mix and match,
Okay, so mix and match is another, and trifocal, of course, where
beautifully well.
Perfect.
What would you mix with? Which two lenses?
Dominant, M+X non-dominant, or minivel and minivel Proxa. I have done very few.
Minivel Proxa, what is your?
I have just done.
62-year-old farmer, profession, not much of reading, no driving, very short in height. Why the short in height is very important? Because the near reading is very close.
Yeah,
I would go for a trifocal or very high addition.
Yeah. If he doesn't do reading, maybe a monofocal also.
Yeah. So of course, monofocal is out of question now with EDOF. 62-year-old professor by profession, not much of reading, no driving, very tall in height.
I think I would put in a trifocal Zeiss. Zeiss trifocal. You know, their intermediate is 80 centimeters. So if he's very tall, I think I would do that.
50-year-old surgeon, I think he has already answered that. 50-year-old lawyer who with reading work, not much of driving.
I would put an EDOF because I don't want him to sue me for any problems.
40-year-old shopkeeper.
I think intermediate is important for everyone. So most of EDOF, the beauty of EDOF is it fits in all categories. So you really don't have to scratch your head. You can just put EDOF and sleep peacefully.
About shopkeeper, they have to read MRPs, which are really small fonts. So you have to
Yeah.
be really, you have to speak with them what they really want. I think regarding ophthalmic conditions, we have already spoken that these are, apart from the ones which cause decentration of lens, I think most of the cases we can go ahead with EDOF IOLs. Of course, it's case to case basis. I think the time is already finished, but if there are any questions, I think high angle alpha is one of the things, whether you would go for a particular lens when there is a high angle alpha.
Again, I think my experience with high angle alpha in EDOF lenses has been very good. I
Good,
mean, while I would be very critical of or very wary of using a trifocal, with an EDOF, I think you can. I have done a high angle alpha. I think the lens was around plus 30, if I'm not mistaken, and it did very well. Yes.
Yes. Any questions from audience? Otherwise, I will just. Yeah, I think I had.
Ophthalmic
kept
surgeon, EDOF. Yeah, he was minus 8.5. No, no, no. The Vivity does not. Vivity is on the IQ platform, so it can adapt to capsular bags of any size. It's available from 10 to 30.
Regarding high myop and high myop, one thing we have to understand is that.
Huh,
That's okay.
It's
Actually,
available. It's available.
whenever you are using lens in high myopia, understand that the actual near addition which the lens gives is reduced. So if you are giving plus 1.5 addition lens, they will require more near. So high myops, lower IL power, you should use higher add lenses. Hyperopes, it is opposite. That's why hyperopes are very happy with multifocal, because their actual, the effective near addition is much more than actually which is there in the IOLs. Okay, so this is just about the optics which are there. So I think the next session is going to start soon. Okay, thank you so much. I think I'm, of course, will be there to answer many questions outside the hall. Thank you, Dr. Nitin, Dr. Nagwekar sir, and Dr. Kumar. We had very short notice to prepare this presentation. We were in, he was in Srinagar, I was in Northeast, so I'm